I was walking around the hospital last week, and I was going down the hallway. I noticed I had 2 stethoscopes, one in each pocket. And so I kind of said, oh, stereo. Well, here I am again. I'm going to talk essentially about early lung cancer, some of the older methodologies and some of the newer methodologies. And if I'm not speaking loud enough or not clear enough, let me know. So the subject is radiosurgery of the lung. And this is a term coined in the 1950s by, not of the lung, but radiosurgery by the Swedish neurosurgeon Lars Leksell. And Dr. Leksell was way too far ahead of his time. He learned how to use really poor quality radiation in an array that you could treat the trigeminal nerve as it exits the pons. And I don't know if you've ever heard about trigeminal neuralgia, but it's called the suicide disease because it's the 7th nerve or 5th nerve, and it's sensation. These people have horrible electrical, burning, sharp, stabbing pain, and even the wind brings it on, and even brushing your teeth or talking brings it on, and they can't escape it. And so it's so horrible that traditionally people have died. Well, Leksell figured out a way using really poor technology, and remember, no even CTs or MRIs, how to treat this. So that's where this term radiosurgery, and he coined the term surgery, neurosurgeon, because you could sculpt out whatever distribution of radiation in any contour. So that's where this all started. So this device is the latest iteration of a linear accelerator. And the person lies on this hard carbon fiber table. And it's hard by design because you don't want them sitting one way one day and another. And so they get whatever body part underneath this head of this machine. In the old days, it would just spit out some big, broad dose of radiation. And nowadays, I like to say shotgun, nowadays it's rifles. And so what can happen while this person is sitting on this, what we call it the couch can move left and right and up and down. This device arcs around in 360-degree angles, and then there's a device in here called the multi-leaf collimator, which shapes beams as it's moving around. So typically treatments are all called arc therapy, where they get squared up on a table, and then they have this machine rotate around. Might take a minute and a half for treatment. Takes probably 15 minutes to get them squared up. So this is an accelerator. Anyway, these are $3 million, and the room's $2 million, and the contract for maintenance is $80,000 a quarter. So all this technology is horrible, as we all know, and we spend 18% of the gross domestic product on healthcare, and it's only getting worse. So, as we all know, lung cancer traditionally hasn't been picked up until late stage, almost always stage 3. Hilar or mediastinal nodes or contralateral higher nodes. So over the decades, people tried to do screening. And what they did for screening for lung cancer was cytology and chest x-ray. And what it did was nothing. Didn't work, but kept going on. Well, more recently, they're screening low-dose CTs without contrast that pick up on these little parenchymal nodules. And indeed, that picks up on some early cancers, but the number needed to screen versus treat is a bad proportion, like 100 scans for one finding. So screening's been going on, and because this basically, it's high-risk patients, smokers. 85+% of people who smoke, or 85% of cancers of the lung are tobacco. Hence the nice little picture there. So it's a bad disease, as everybody knows. It's 250,000 people a year in our country. It's 110,000 females, so that's rising, and it's roughly half of this, or a little bit more percentage of the males are getting lung cancer, but the incidence of female cancer is going up. And so if you look at all of people who are diagnosed with cancer, this is an example. I'm confused here. The 1,100 and 1,300, that's the state of Iowa. I was going to talk about epidemiology, and Nebraska's got 1.9 million people, and California has, 45 million people. So kind of a garden variety state is Iowa. So in Iowa, 1,100 women get lung cancer, and 1,300 males get it. And the proportion of females is higher because they're smoking more. And of these 1,100, 68% die of their disease. Same thing in men. Breast and prostate cancers are far, far more frequent. However, the minority of them pass away. So it's a public health issue, as we all know. And these folks who are diagnosed with lung cancer, that's usually not their only theme. As you can see, they may continue to smoke, they have pulmonary vasculature issues, hypertension, heart disease, COPD, etc. So when you find these folks, not all of them are candidate for a thoracotomy. And in fact, if you look at all these people with early stage disease, about a third of them are felt to be medically unresectable. And if you look at people with just T1 lesions, their average survival without any treatment is just slightly over a year. And if you look at people with T2 node negative, median survival is 8 months. So untreated, which is maybe a third of early cases, is a disaster. So the standard is this. And it's a lobe and a formal dissection of the mediastinum and hilum. And thankfully now there are some cases that can be done through the thoracoscopic surgery, so you don't have these huge incisions that can cause post-thoracotomy pain, et cetera. But not all these people who have these early diseases, as I said before, can't have a surgery like this, or even a lesser invasive surgery. So what do you do with them? So what's been done is maybe just treat them like regular people with radiation. Long course of divided treatment over a month and a half or so. And if you look at that, we don't do very well. At 5 years, we only have local control in a third, and at 5 years, only 10% survive. So this is an early stage T1, T2 tumors, and they don't do well. And it's probably because the way the radiation works. The conventional radiation destroys DNA. And everybody knows that's the blueprint. And the mechanism of cell kill ordinarily is radiation disrupts the double helix bond and it becomes oxygenated. We all think about antioxidants. Well, maybe you shouldn't do that during radiation, but because of oxygen atom that's radical, unpaired electron, so it attaches to something. And if it attaches to the bumper of your car, it's rust, iron oxide. If it attaches to DNA, it's DNA injury. And the thinking is normal tissues can repair that DNA damage and malignant tissues can't. Normal tissues need some time. So traditionally we just divide this radiation apart to pieces because the technology over the last 100 years has been really horrible. I mean, everything gets irradiated. So you have to allow time for the normal tissue to fix itself where the cancer can't. And I have to put this slide in every talk. This is, sorry Debbie, this is radiobiology in a nutshell. When early on, the Europeans were messing around with radiation, very low dose radiation. They wanted to know, how can I sterilize the spermatogonia in the testicle and not make the scrotal skin erythematous? And what they learned is, well, some tissues handle radiation better and some don't. And some of the most sensitive tissues in the body for radiation are epithelial tissues, like where the spermatogonia come from. Also, however, skin is a renewable tissue, and fast tissues respond to radiation. But what they learned with this experiment, I don't know how they got the grant money, but they learned that they could sterilize the ram and preserve the skin. And that would kind of is the main biology of traditional radiation. How can you kill tumor but not kill normal tissue? So that's what this is all about. And as I said, this radiation hits a water molecule, strips off an oxygen atom. Our electrons like to be paired, and an oxygen atom has an unpaired electron. So what does it do? It looks for another oxygen atom, O2. Well, in the case of this radical that's formation, it hooks onto the DNA, and it disrupts the DNA. Evidence for this is kind of like back to that nutshell thing of tanning booths. People are going to go to the Caribbean and say, oh, I want to get a tan so I don't burn when I'm on the beach. Well, sure, but you're outpacing the repair mechanisms. Yeah, you get 8 hours of sunlight and 10 or 15. And what happens is they outpace their DNA repair. Yeah, they get tan, which is actually a defense of the body for injury, but they get tan, but they get skin cancers, melanomas and basal cells and squames. And of course the tanning booths say, no, it's UVA, not UVB or whatever. It causes cancer. Tanning booths shouldn't be used, in my opinion. Other evidence of where this is happening for DNA was the DNA is in the cytoplasm. And you can use these little micro things and put little radiation on the nucleus of the cytoplasm. If you put that little radiation probe elsewhere in the cytoplasm, it doesn't cause DNA damage. But if you put it on the nucleus where the DNA is, they die. And there's horrible things in this regard. I don't know if you've ever heard of xeroderma pigmentosa. It's a horrible disease of children because they don't make it into adulthood. These are the kids that can't go out in the light because they don't have DNA repair. It's very interesting how the body works. We have this DNA molecule and we have enzymes called restriction endonucleases, and they read the DNA to make sure it's properly aligned. And if they find an error, they snip out the section and fix it. Restriction endonucleases. Well, children with this disease don't have that. So they die of thousands of skin cancers in early life. It's horrible. More evidence about DNA. If you have a cell that has more and more DNA than a conventional cell, they die easier. And then this is an interesting fact. You've heard about irradiated blood cells for transfusions. You're irradiating these cells, aren't you going to kill them? Well, mature red blood cells don't have nucleus, don't have DNA. So you can irradiate red blood cells and they don't die off necessarily. But the white cells that might contaminate them do have nuclei. So that's how we sterilize the white cells, which cause transfusion reactions. So here's my buddy, Dr. Lexell, and his term radiosurgery. And he said it's the delivery of a huge amount of radiation to a very small volume. And at the time, it was for only CNS, so they could do this without doing a cranie. And that's the term radiosurgery. This is his early getup. Those are really crude little X-ray tubes. And the device that's around the head is basically a GPS system that helps design where you could put these beams at. So this was the term radiosurgery. Or sometimes it's called stereotactic radiosurgery because it's, again, this GPS system. And there's all kinds of versions of this, and nobody really knows what the term radiosurgery is, except for Medicare, because they say it's only 5 treatments or less, whereas a traditional prostate patient gets 40-some treatments, or lung gets 30-some, or breast gets whatever is required. But this new radiosurgery is really compacting this radiation, and by Medicare's definition, it's 5 treatments or less. But people are treating prostates and 10 treatments. Well, that's not radiosurgery. It's kind of a definition that really doesn't make any sense. The idea of this conformal radiation is so you don't obliterate the adjacent tissue. Salivary gland, brachial plexus, spinal cord. So it really helps us further define targeting. And there's all kinds of different terminologies. SBRT, stereotactic body radiation therapy. SART, stereotactic ablative radiosurgery. Conformal, just a terminology of how do you get this. And IMRT. IMRT came on the scene about 20 years ago in this country, and that was using 40 beams maybe as opposed to 3 beams. And VMAT is a version of those hundreds of beams, but it's delivered, as you'll see, in a rotating manner. And then there's a thing called Gamma Knife, which is really what Lexell came up with. And that's a sexy name, so there's all kinds of Ford, Chevy stuff out there. So there's CyberKnife, and you'll hear all this kind of stuff. But it's all kind of the arms race that radiation oncology technology suggests. So back to those early stage patients. A guy named Ginsberg did a study, a randomized prospective trial. Remember, that's when you do compare apples to apples, not apples to oranges, follow in the future. And so what his thought was, well, maybe we can do a lesser invasive surgery. As opposed to a formal lobectomy and nodal dissection, let's just do a wedge, therefore taking out less lung parenchyma. Turns out that didn't help. Turns out that recurrences were about double. And so conventional radiation didn't work, wedge resection didn't work. Well, then along, people start thinking about this radiosurgery guy, Lexell, and maybe we can do this to lung cancers or brain tumors. And going back to that, what this radiosurgery would be is just treatment here, wherever. And it wouldn't treat the nodal basins. It wouldn't take the wedge out for me. It would just be a spot welding of the focal area. And we already know from wedge resections that that doesn't work. You need to have a more formal dissection. So how can we get away with doing what was shown via wedge versus lobe? How can we get away with it? Because essentially we're doing a wedge with radiation. Well, as everybody knows, technology and staging and molecular assessment, et cetera, is increasing. So we're getting a better idea of who might be a candidate for a wedge as opposed to back in the 90s when Ginsberg was doing his work, didn't have scans and so forth. So there's a thing called stage migration, or the AKA Will Rogers. And I don't know if anybody knows Will Rogers, but he was a cowboy who had really cool sayings. And there's a Will Rogers effect. And what that stated was people emigrated from Oklahoma to California, and the IQs went up in both states. But essentially what it means is we have better staging, genomics, MRI, CT, PET. So the early stage ones that we had before perhaps weren't early stage, and that's why wedge might have not worked. So we have stage migration. And here's an example. Here's our right middle lobe mass, a little bit spiculated, shows up on scan. You'd worry certainly about all the lymph nodes higher up and in the mediastinum, but all we knew was this. How could we get away with just treating this and not all this other stuff like that lung cancer study, wedge versus lobe, which didn't work? Well, here's an example of stage migration. This lesion is that lesion. And if you scan through the rest of the mediastinum and lung parenchyma, you don't see anything anywhere else. So we have a little bit better idea that maybe this really is a stage 1 T1N0 as opposed to many ones back in the 90s when we don't even have good CTs necessarily. They might have had nodal burdens. So hence that's why the wedge didn't work versus the lobe and dissection. So now we're back to this, well, can we do a wedge and not a dissection of the nodes? Well, maybe we can because we have better staging migration. This is a lady I saw yesterday in clinic, 47, professional smoker, showed up with this lesion on your right side, your left side. And she went through, and you can see, it doesn't show really well, but she's got all these blebs all over the place. And if you go higher up into her apices, even more blebs. Really poor pulmonary function, couldn't go upstairs. So she was treated with this type of radiation where she got a big blast of 5 treatments, and this is what happened to her. You get all this scar, but her tumor was gone, and it was gone on PET. But as we were following her, we found this new lesion. And it too is biopsy proven to be a non-small cell lung carcinoma, just like the original one, thought to be a second primary. Saw her yesterday, she's got brain mets. And maybe this thing on the contralateral hemithorax was not a second primary, which was our assumption, because nothing showed up our staging, but maybe this was a metastasis, as was the findings in her MRI of the brain yesterday. So the question is, who is a candidate for this kind of fast radiation to a very limited target? Well, like any cancer, you have to supposedly do an H&P. The joke is if the CAT scan's negative, you better do a physical. It's kind of true, I hate to say. But you pick up on things and weight loss, and so much of our information is history. So we have all these scans, CTs, brain MRIs, PETs, fused PETs, physiologic studies like split perfusions, pulmonary functions, and then as I was indicating before, more and more with stage migration, we're getting a lot of interesting genetic information that can predict behavior and therefore allow us to figure out who might be a candidate for just a very localized procedure. And you also have to see how long these people are going to live, and of course nobody knows that. A lot of these cancers we find in people, they're very curable, but do they need to be cured? And of course the answer to that question is how long do they live versus how fast do they grow? Women in their 70s who die of non-malignant cause upon autopsy have thyroid cancer. Men in their 70s, 72% of them have prostate cancer. They're curable, but do they need it? Well, that's kind of this last point. Do they benefit from the cure? Well, nobody knows that. The people have to have certain features, too. By design, not by error, I showed that accelerator, and it's got this really hard carbon fiber table, not a nice celipostric thing. Can they lay on it? And a lot of people are all crinkled up and arthritic and can't get there, or old. You also have to do an extensive amount of physics work. And I'm going to show an example here shortly, but many people have heard about 4D CT. Conventional CT is this way, this way, this way. Well, 4D CT is all that with movement because things move when you breathe. So they have to have a 4D CT scan, which I'll show eventually. We have 4 PhD physics people in our department, and they are the backbone of our treatment. And their involvement is extensive. If you treat a person in 5 treatments or a total treatment time of 7 minutes, probably 30 hours of physics work to accomplish that. And we also have to know, well, okay, if you see something on a CT, well, is it just there or is it more? Because cancer, when first described by the Greeks, before they even knew what cancer is, said these little growths, they extend beyond the main ball like a crab. And the original word for cancer was like cankers or canker. So if you look at the zodiac sign for cancer, it's a crab. Well, how can we just target this thing that shows up on scan where there might be microscopic extension? So pathologic studies say, yeah, well, it really doesn't go that much far beyond what you can see grossly with imaging. It's about 6 millimeters. So when we do our planning, we not only account for the movement of the tumor, the size of the tumor, but the microscopic extension. So when people go through planning, it's essentially a CT scan, and you have to help them understand this because they've already had PET scans and pulmonary functions and CT chest, and why am I getting another CAT scan? Well, it's a contrasted CAT scan typically. It's done with this 4-dimensional issue, but it's really a physics CAT scan. How does radiation interact with the body, and what's the density of the tissue, et cetera. So we get these planning CAT scans, and we contour in the esophagus, and the hilum, and the major pulmonary arteries, and the lung parenchyma, and then we say, well, I want this thing to get this much radiation, but I don't want these other things to get any radiation. So there's a person called a dosimetrist, and they're a computer jockey that takes all this information and comes up with numerous iterations of how we can get these beams arranged to hit the target and avoid the normal stuff. And it goes through quite a bit of a quality control process. In our hospital, we have 5 radiation people. They all look at each other's work. We have 4 physics. They look at each other's work. We have a meeting every week to make sure we're all on the same page. So there's a fair amount of upfront planning. Now, as I said before, the cell kill traditionally is DNA. And because it was DNA, you had to allow the normal tissue surrounding it with DNA time to repair. Well, now as we're getting really focused on this target, we don't have to worry so much about the surrounding tissue exposure to radiation. We're not limited by their repair time. And so it's been learned that it really isn't DNA. It's really the blood vessels change. And I've studied blood vessels when I was in training, and they're kind of Walmart blood vessels. They have no vasomotor control, they leak, they have sinusoids that go all over the place, they have dead ends, and they rip easy. And so some of this damage by a huge amount of radiation is you change the vascular permeability. A lot of people get the idea that you're doing some sort of cautery thing, but it's not that. It's these small photons. And as you've changed the vascular permeability, the osmotic pressure changes, and this is really a huge, huge discovery. It causes an inflammatory reaction. Cytokine release, which is an inflammatory mediator. And increasingly, people are using radiosurgery with various immunotherapies that take advantage of this immune response that's mediated by the cytokine, by this huge amount of radiation. You might also remember the cell has a lipid bilayer, the cell membrane. Remember, we don't have cell walls like plants, but the membrane is this layer of fat, and it's polar with some of the positives on the outside and the negatives on the inside, and that's how we take advantage of calcium channel blockers and so forth. Well, this bilayer gets disrupted. The energy of the cell, the powerhouse of the cell, is mitochondria, and they open. And then long term, the blood vessels scar down, and tumors, like anything, need a blood supply. Well, you can ablate the vessels. And as I mentioned, immunostimulus. So yeah, back to these vessels. They're just horrible. They don't perfuse well, they flow, they don't flow. You might have heard of tumor necrosis. They're growing so fast they outgrow their blood supply. It's just a really poor anatomy for sustaining a cell. As I said before, they don't have any ability to vasoconstrict or vasodilate. They lack the muscles on the lining of the vessel wall to do that. Um, Actually, as tumors grow, they have less vascular density. If you do a biopsy of a heart on an athlete and a biopsy of a potato, couch potato, and you look at the capillary density, you can absolutely tell who's the runner and who's the potato. Well, in similar fashion, as tumors get bigger, they don't have really good perfusion. They outgrow their blood supply, hence they die. And then along with that is they're low in their oxygen. And as I mentioned before, well, doesn't radiation need oxygen, split off a water molecule, and make this unstable oxygen radical attached to another one, oxidation? Well, if you don't have oxygen, you don't have that process. And so all this new radiosurgery stuff in the biology of cell kill really isn't DNA. It's really all these other methodologies. Vascular permeability, cytokine release, fibrosis, completely different biology. So part of the issue is when you're treating somebody with a very small field, that field moves around. And even prostate cancer, when they go through radiation, they'll have 3 or 4 millimeter changes in their position every day. And if you're really focusing on the small thing, well, that thing might not be in the pathway of the beams. So this is called tumor that's called motion management. On the one side, you can see this is a 3D conventional CT, and you just see how splayed and choppy that lesion in the right hemithorax, hilum, etc. And you can see these. This is the diaphragmatic muscle right here. You're catching it in this position during a phase of respiration, and this position in another phase, and this is all jumping. Well, if you add the time factor, the diaphragm isn't moving, or you're catching it at a certain moment in its respiratory cycle, and you can therefore have a better tumor delineation. So that's 4-dimensional CT, X, Y, Z, and time. This is an example of what I'm talking about. This was that lady who I told you had brain mets as of yesterday. This was her first lesion. And this is, of course, a coronal, and this is a sagittal, and I hope you can appreciate this. But this is, you can see the heart moving, contracting and so forth, the aortic arch moving. But also look at this hit right here. That's moving in position. And so how do we know where that motion is relative when the beams are pointing at this? Well, you do it by 4D CT, and that way you can treat in phase of respiration. So as this thing's arcing over you, it's beam on, beam off, beam on, beam off, well, it's coordinated with phase of respiration. And here's the sagittal. Same thing, up and down a little bit. Diaphragm moving. This was the very first guy we did. This was in 2000. Jeb, you would probably know. Remember the first radiosurgery we did? Remember we were always looking for those parts, and we finally got. Was it 2008 maybe? About maybe 8 or 10 years ago. Well, this is the first guy, and he had a biopsy, and then he had this disaster. You can see the chest tube on his left. You can see all that subcutaneous air, and after his biopsy, which was CT guided, he developed this horrible pneumothorax, and you can even see air under the diaphragm, free air. And you really, when you look at a chest X for pneumothorax, you usually see it in the apices, but he has free air here, and then all the subcutaneous air, which I don't know why they call it, but it's subcutaneous emphysema. I don't know if you've ever seen it, but it's like bubbles for packaging. You can press it, and it just pops. And he was hooked up to the wall for 5 weeks. And he was thought not to be a candidate for thoracotomy or thoracoscopic surgery. So he was our first guy that underwent radiosurgery. And because he was hooked up to the wall for this month and a half, we decided to treat him with his chest tube in. And this was the old version of how we did this. This is actually his CT scan. And you can see these different colors of squares coming at him. Well, that was the initial way we did it. 7 or 8 or 9 different beams coming from different directions. Now it's an infinite number of beams. And this is that guy. Here's his subcu air. Here's his lesion, very stellate. Because of motion management, at the time we weren't doing very well, so this yellow is what we had to treat to make sure this was in the volume of our irradiated tissue. So we had a little margin. And then this represents dose of radiation that is within lung tolerance. But we're still taking a fair amount of the lung out, but much less than a formal lobe. Well, how do we know that we're really tracking this? Because again, it moves. So nowadays when people do radiation, it's called image-guided radiation. And that's not the little Pac-Man eating the tumor cells, it's CT scan. So they have these planning CTs, get all these contours and anatomy and what gets to be treated and what shouldn't be treated. Well, you have all this physics stuff, but you can't execute it on a patient. Well, it's nice physics, but not good treatment. So now there's image guidance. So what happens is they have this planning CAT scan, and then every day during treatment they have a CAT scan on this treatment table. So that accelerator I showed you is not only a radiation machine, but it's a diagnostic CT scan, and we can do windowing. So this was his diagnostic scan. I mean, therapeutic scan. This was his diagnostic scan, and I windowed the way I wanted to window it, but we do this thing here, and we can make sure that this is the same and different. We compare the orientation and the planning scan to the treatment time, and it's such nice tolerance. If it's off 2 millimeters, we make a correction on the person. So the point being, we don't have the slop factor anymore. We've created a problem. In the old days, it was just this shotgun that got everything, and it was in there somewhere. Well, nowadays we're doing this very small volume. Well, how do you know where that is? Image guidance. And then treating in phase of respiration, again, because it moves. This is my other slide that I always put in, and I can't remember why I put it in this time. This guy is Sir William Osler. He was considered to be the father of modern day medicine. And he grew up in Toronto, Canada, and made his fame and fortune in Cambridge, and he was a very eloquent writer. So there's a book, this must be why I put this in. He has a book called The Eloquent Osler. Little vignettes about, most pathology is vascular, and if you kind of think about it, yeah, that makes a lot of sense. Well, he also said this, and it's very eloquent, but I'll paraphrase. And it's kind of true what he says. He says, medicine is the science of uncertainty and the art of probability. And that's really neat, but kind of means we don't really know what we're doing sometimes. But anyway, that was Osler. If you want to read a good book, read The Quotable Osler. So again, back in any kind of treatment for heart or GI or cancer, you have to have randomized prospective trials. 1,000 people with T1 lesions, same comorbidity, they get surgery. 1,000 like patients who don't get surgery, they get radiosurgery. They can't choose, we can't choose. It has to be apple to apple, and they follow them in the future. That's randomized prospective data. And we don't have that because we know that we know that lobe and dissection is the standard. And you hate to de-escalate by doing lesser than that. So how do we know that radiation is really, I don't know about that. Well, maybe we'll do it on these people who aren't fit. Yeah, let's try that. Well, it turns out in these retrospective experiences, these non-randomized data here, that local control is pretty darn good. That first guy on the top, his name is Onishi, and the Japanese and the Americans were the first to really start this treatment, and they have a 5-year local control of almost 260 patients. They have a 5-year local control, as what you see, which is actually better than any thoracotomy series. Other data in this country and elsewhere, similar findings. Second study, local control 89%. Study from Colorado, 3-year local control. Fewer patients, but 93%, etc. Bob Timmerman is one of the pioneers of this procedure in our country, 95%, but only 2-year follow-up. So an attempted study was carried out at MD Anderson, and people might have heard of MD Anderson. It's a very big cancer hospital of note. And the chairman of thoracic oncology, who makes his living by cutting, he wanted to do a study, a randomized prospective trial where half to get thoracotomy and half get radiosurgery. Well, didn't get enough statistics on this because nobody wanted that kind of randomization. What do you mean? You want me to have this treatment that isn't as proven as thoracotomy? So it had poor accrual. But when they looked at their 3-year local control, radiosurgery, again, non-randomized, was superior to surgery. Kind of interesting. So this is what happened. So here's that machine we were talking about. And here's this person. And I hope you can see this, but what will happen is this machine rotates around in 360 degrees or whatever circumference we choose. This table, you won't be able to see it. This moves its angle and its pitch and its roll. And then inside this thing where it shapes the beams, they continue to move. So as this thing's rotating around you, up in the head of the machine here, these little beams are changing. And this thing's rotating around, and the table's rotating around. And so this is, I hope, a depiction. What you're hearing is what is heard on the monitor. The patients don't hear that. But you can see this is slowly arcing around. And that sound you're hearing is what the therapists hear, just to make sure they know that something happened in that room. These people don't hear it, but it's a reminder that this beam is being spit out. And this blue arrow depicts that this part of the machine, as the whole thing is rotating, and the sub part of the machine is rotating around. So that's a bunch of physics jargon. I hope they didn't catch me saying anything. This is an entire treatment. Minute and a half. 5 treatments. Outpatient. This is another depiction. Remember I said in that head of the machine there's little things that are shaping the beam? This is a depiction. So here's a digital reconstruction of their chest as this thing's moving around. Obviously spine. This is oxygen. This is table. And depicted in green is the target. And then you see these little yellow rectangle things. Well, that depicts these things moving. And you'll see this in this picture. So this is representing the target, and all those little leaf configurations or rectangle configurations are different angles of the beam shooting different configurations of the beam itself. And if you could see, this is a cartoon of what's happening. And this is rotating here. This huge thing is rotating. And again, you can't see all this very well, but this table is rotating sideways, up and down, and left and right. Interesting tech. So, bottom line is radiosurgery is here to stay. It's not only used for unresectable lung patients, it's used for metastasis. It's being used, its start was CNS, brain tumors, etc. It's being used in liver, it's being used in spine. I just got back from a meeting on the updates on this stuff. It's fascinating, interesting things. If a person has a brain metastasis, or a big person has 9 brain metastases, you can treat them in 2 minutes and not treat the other brain parenchyma. So really spares a lot of tissue. The biology is different. It's not DNA. It's all these other lipid bilayer things, cytokines, etc. Really pretty interesting technology. Earliest development, been around for about 15 years. My prediction is that when people train in this field, they will subdivide into conventional radiation or radiosurgery. So, neat technology. It's just not geeky. It seems to be of great utility. Going to keep doing it. Anything else I should know or you should know? There's a lot more I should know. But oh, and one more thing. Bad disease. And we can no longer go by what the Cheech and Chong joke is. You ever hear the Cheech and Chong thing? I cut my smoking in half when I had my lung removed. This is what we've got to do. Crush those smokes. See this, Deb? All right, well, thanks a lot.